I'm going to talk about the impact of COVID-19 pandemic on the severity and mortality of ischemic stroke in the southeast of Santiago de Chile. I'm Andres Silva. I work in a comprehensive stroke center in Santiago, and I represent to the team of the Southeast Santiago Health System. As an introduction, as you know, COVID-19 first cases was in December 2019. It has a rapid pandemic expansion with a mortality of 2.3%, and to date in Chile we have about 1.6 million cases and 37,000 deaths. As you probably also know, there is involvement of the central nervous system with direct invasion through the olfactory nerves, through retrograde axonal transport, gut-brain axis, and hematogenous spread, and it has been found in the cerebral spinal fluid, the COVID virus. It has an important association with neurological symptoms in about 88%, with the principal symptoms are hyposmia, dysgeusia, headache, consciousness, commitment, and dizziness, and about one third, 36.4% have a neurological disease, where stroke is an important one. There is an association of respiratory viruses with stroke. SARS-CoV-1 in 2003 have a stroke rate of about 2.5%, with a mechanism principle of hypercoagulability, also inflammation and fibrinoid necrosis. And MERS-CoV in 2012 occasionally associate to stroke with an immune-mediated mechanism. The principal study about the rate of stroke is this theory about of the Dr. Nannoni, with a stroke rate of 1.4%, with about 108,000 patients in the study. So there is a relation that is two ways. For one part, SARS-CoV-2 is a cause of stroke, with a 6% of stroke in severe infections in the patients in the ICU, 1 to 3% in total, and there is also effects of the pandemic in relation with this sanitary system collapse and increase in mortality that is shown in various studies. Also, stroke is a poor prognostic factor for COVID. The prognosis worsens by 3, and mortality is about 10%. So we as a team decided to study the effect of COVID-19 in the stroke patients in our area in Santiago de Chile, in the southeast of Santiago de Chile. We decided to conduct this study because Chile in one moment was one of the countries most affected by COVID-19, with one of the highest case rates per population, and because we know for other publications that the epidemiological behavior of stroke in Europe principally is what was affected. So the southeast of Santiago is a highly populated location. We have all these locations in this area with a total population of about 1 million and a half inhabitants. It's almost the 10% of the population of the entire country, and about the 8% of the beneficiaries of the public health system. We have 4 hospitals in this area. In San Jose de Maipo Hospital, that is a community hospital with a rehabilitation approach. 2 primary stroke centers, Eloisa Diaz Hospital and Padre Hurtado Hospital, with the capacity of intravenous thrombolysis 24/7 and a stroke unit, and a comprehensive stroke center, that is the hospital where I work, that is Sotero del Rio Hospital, with a capacity for intravenous thrombolysis and endovascular thrombectomy 24/7. We also have neurosurgery and a stroke unit. So we work as a hub and spoke model, where the 2 primary centers can do thrombolysis, but when they need endovascular treatment, they send the patient to the Sotero del Rio Hospital. We conducted a multi-center observational study based on the records of 3 hospitals, Eloisa Diaz, Sotero del Rio, and Padre Hurtado Hospital. We recorded the number of patients admitted for ischemic stroke between January 1, 2020 and June 30, and we grouped the cases in 2 periods, pre-pandemic and pandemic, separated by the declaration of the state of emergency in Chile that was about 13 March. So the results of our study, the first table shows in the first part that there was a slight decrease in the COVID patients and in the stroke patients that came to our hospitals. It was not significant, only significant in the Eloisa Hospital. There was no significant difference in terms of gender or age, but it was a significant and important worsen in the NIH stroke scale. There was no difference in terms of the treatment that patients received, medical, intravenous thrombolysis, or endovascular treatment, that were about 10% intravascular treatment and 5% for endovascular treatment or associated treatment with intravenous thrombolysis and endovascular treatment. Obviously, all the patients with COVID-19 were concentrated in the second period where the pandemic started, and the mortality grown from 5.2% to 12.4%. That was also significant. The important outcome was this growth in mortality that was about 2.4 by 2.4 fold. So we analyzed, we did first an univariate analysis of the mortality, and we found that there was an association with being in the second period, in the period of the pandemic, with the age and with the NIH at the in the emergency room at the when the patient arrived. And later we did a multivariate analysis where we find that the only factor, the principal factor that associated with mortality was the NIH and the
Score.
arrived of the patient. So results, we found an increase in the severity of stroke on admission and in hospital mortality during the pandemic period. The main factor in the increase in hospital mortality was the NIH stroke scale at admission. As a discussion, our study is one of the first records of the epidemiological behavior of stroke during the pandemic period in Latin America, and one of the largest numbers with the largest numbers of patients. It demonstrates a significant increase in severity measured by the NIHSS and mortality in patients admitted for stroke in the Southeast Health Service of Santiago. And possible explanations are first, the lower rate of consultation of mild cases due to fear of contagion with COVID. Second, poor control of chronic pathologies for the sanitary health system collapse, and alterations in management due also to the sanitary collapse, like the less the lack of ICU units and medical personnel. The strengths of the study are that this is a multi-center study carried out in the public system in Santiago, in an area where the vast majority of the population is cared for there. And limitations are that this is an observational study. The etiology of the stroke and the percentage of great vessel occlusion were not recorded, and mortality measurement is in hospital and not at 3 months. Thank you very much again for the invitation.